Welcome to the deep dive. Today, we're really getting into the weeds on something quite critical, actually a very detailed, systematic protocol, the kind used for admitting and prepping a patient for emergency vascular surgery.
That's exactly right. And this isn't, just some generic checklist. We're looking at excerpts from a specific admission protocol emergency surgery. It's used in a specialist vascular unit, and the source we have attributes it to Dr. Gregory Weir, a specialist vascular surgeon.
Which shows you it's grounded in practice, right? Designed for those high-pressure situations.
Absolutely. It screams real-world application.
So our mission today is, well, to unpack this. It's basically a roadmap, step by step, for managing these acute vascular crises from the second the patient arrives. We want to go beyond just what they do.
And really dig into the why, the clinical thinking behind every single action, understanding how it all fits together to manage patients quickly but safely in these really acute settings.
Exactly. It's appreciating the careful architecture of it. So we'll follow the patient's journey just like the protocol does, starting with arrival, identity, that sort of thing.
Then the immediate tests, the stat stuff, and then there's a big chunk on the preparation phase, all the things that must happen before theater.
Before they even get near the OR. And finally, we'll touch on that transition getting to theater and where they go right after.
Sounds like a plan.
All right, let's dive in. Section 1, patient identity. Right at the very beginning, the moment of arrival. It seems basic almost, but I guess in an emergency.
It's absolutely foundational.
Yeah.
The protocol puts it first, and for good reason. It states clearly, confirm patient identity immediately. And it mandates, interestingly, a multi-pronged approach.
Multi-pronged. How so?
Well, first, use the hospital sticker. That's your documented piece. Then, crucially, get verbal confirmation directly from the patient, assuming, of course, they're conscious and reliable enough to respond.
Okay, sticker and patient verbal confirmation.
And the third leg, which is vital in emergencies where the patient might be, confused or unstable, is confirmation from any family members present.
Right. So hospital sticker, patient, and family. Let's pause there. In these emergencies, a limb going ischemic, maybe a ruptured aneurysm every second feels critical. Why dedicate time to 3 ID checks? Isn't speed the absolute priority?
It feels like a delay, but it's actually preventing a potential catastrophe. Think about it.
Yeah.
The consequences of operating on the wrong patient or doing the wrong procedure on the right patient because of an ID mix-up, they're unthinkable, irreversible.
Okay.
And emergency situations are just ripe for error, aren't they? High stress, fast pace. The patient might be in severe pain, hemodynamically unstable, maybe altered mental status, making their own confirmation unreliable.
Right. You can't always trust what they say in that state.
Exactly. And hospital stickers, they can get misapplied in the rush.
Yeah.
And information might be entered wrong downstream. So having the family there, assuming they're reliable and properly identify themselves, provides that independent check.
So it's about redundancy, multiple layers of safety.
Precisely. You're combining documentation, the patient's input if possible, and family confirmation. You build these barriers. For a mistake to happen, all 3 checks have to fail. It's not a delay, it's a fundamental safety step, ensuring the urgent care goes to the right person.
That makes perfect sense. You absolutely cannot get that wrong. And the protocol adds something else here, something more. Human. Welcome the patient and family and assure them that we are here to help the patient as urgently as possible.
Yes, and I think that's really important. It integrates the human aspect right from the start. Imagine being that patient or that family member. You're probably terrified, in pain, facing huge uncertainty.
Absolutely.
Just a simple, genuine welcome. And that clear statement, we see the urgency, we're acting now, can make a massive difference. Clinically, well, reducing anxiety might help stabilize vital signs a bit, maybe make the patient more cooperative with all the rapid steps to come.
And it builds trust, right? At a moment when they have to hand over control completely.
Exactly. It acknowledges the person, not just the pathology. It's compassion baked into the workflow, even when things are moving incredibly fast.
So just to recap this first bit, multiple redundant ID check sticker, patient verbal, family because the stakes are sky high, and alongside that, that crucial human touch, welcome and reassurance, sets the tone. Okay, identity confirmed, patients in the unit, what happens next immediately?
Right, so the protocol shifts immediately to diagnostics, specifically stat blood tests. Stat, of course, meaning right now, immediately.
And it even mentions a specific lab. Lancet Laboratory.
It does, yeah, which suggests, a standardized process. Maybe they have a guaranteed rapid turnaround time worked out with them, which is critical for these results.
Okay. And the tests themselves. It lists UKE, troponins, specifically Myoglobin, FBC, and a coagulation profile, INR, and PTT. Quite a panel. Let's break these down. Why UKE first? What's the thinking there in an emergency vascular context?
Okay, UK urea, creatinine, and electrolytes. This is fundamental for a couple of reasons. First, urea and creatinine give you renal function. Why is that critical here? Well, vascular patients, especially those with the kind of widespread atherosclerosis that causes limb ischemia or aneurysms, often have underlying kidney problems.
Right. Comorbidities are common.
Very common. And think about imaging. Things like CT angiography, which we might need, use contrast dye. That dye can be tough on the kidneys, nephrotoxic, especially if function is already poor. So knowing the baseline kidney function helps decide, is CTA safe? Do we need to hydrate them first? Or should we maybe opt for a different imaging type like a duplex scan or an MRA, which the protocol mentions later too?
So it impacts diagnostic choices right away.
Immediately. And beyond imaging, think about drugs. Anesthetics, antibiotics, painkillers, how the body clears them, often depends heavily on kidney function. Getting the doses right relies on knowing how well the kidneys are working.
Makes sense. And the E in UK, the electrolytes, sodium, potassium.
Oh, absolutely vital, particularly potassium. Major electrolyte imbalances, especially high or low potassium, can trigger dangerous heart rhythm problems, arrhythmias.
And this patient group is already high risk cardiologically.
Exactly. They often have underlying heart disease, so ensuring electrolytes are balanced is critical for cardiac stability, especially heading into anesthesia and major surgery. If someone comes in with a dangerously high potassium, for example, you have to address that before they go to sleep. It's non-negotiable.
Got it. So UK gives us kidneys and electrolytes, both crucial for immediate management and planning. Next up, troponins, specifically Trop-T, and myoglobin, cardiac markers. Why are these needed for a vascular, not primarily cardiac emergency?
It comes back to that same issue, systemic disease. Patients presenting with acute limb ischemia or a dangerous aneurysm almost always have atherosclerosis elsewhere. That very often includes significant coronary artery disease, even if they don't know it or don't have symptoms.
The heart is likely affected too.
Highly likely. And the stress of the emergency itself, plus anesthesia and surgery, puts a huge strain on the heart. These markers, troponin T and myoglobin, leak out when heart muscle cells are damaged. Elevated levels can signal an acute coronary syndrome, maybe a silent heart attack happening right now, or recent damage.
Even without chest pain.
Especially without chest pain sometimes, yes. Silent ischemia is common in this group, particularly diabetics. Finding this out immediately is crucial.
Why? Because it changes what you do next.
Precisely. A high troponin or myoglobin flags the patient as being at much higher risk for major cardiac problems during or soon after surgery, like another heart attack or a bad arrhythmia. This tells you they need much closer cardiac monitoring. It might mean getting cardiology involved urgently, pre-op, and it definitely influences the anesthetic plan. The anesthetist will tailor things to protect the heart as much as possible.
And it probably dictates where they go after surgery too.
Absolutely. It reinforces the need for that post-op cardiac high care unit or ICU placement, which the protocol specifies later. You need that intensive cardiac monitoring environment for these high-risk patients.
So you're essentially assessing the heart's baseline and its ability to withstand the upcoming surgical stress.
Exactly. You're trying to anticipate and mitigate that cardiac risk, which is just inherently high in this population.
Okay. Moving on down the list, full blood count, FBC. What key information are we getting from that quickly?
The FBC is like a Swiss Army knife. Lots of useful bits. Hemoglobin and hematocrit tell you about their red cells. Are they anemic to start with? Anemia means less oxygen carrying capacity, which is bad news if a limb is already starved of oxygen.
And it gives you a starting point for blood loss during surgery.
Yes, provides that crucial baseline. Then you've got the white blood cell count. Is it high? That might suggest an underlying infection. Maybe the vascular problem itself is infected, like a mycotic aneurysm, or there's just a significant inflammatory response going on. And finally, the platelet count. Platelets are key for clotting. Low platelets. That means a higher risk of bleeding during the operation.
Which ties nicely into the last part of the panel, the coagulation profile, INR, and PTT. Why is knowing their clotting status so vital here?
Well, vascular surgery, by its nature, involves cutting into blood vessels. Bleeding is always a risk, sometimes a massive risk, so you absolutely have to know the patient's baseline clotting ability. The INR checks the extrinsic pathway. It's often high if someone's on warfarin or has liver problems.
And the PTT?
PTT checks the intrinsic and common pathways. It can be affected by heparin, some of the newer anticoagulants, or rarer inherited clotting disorders. Knowing these numbers is critical because, as the protocol points out later, many of these patients are on blood thinners, anticoagulants, or antiplatelets for their underlying vascular disease.
So these tests tell you if those drugs are working maybe too well.
Exactly. Or if there's some other reason their clotting is off. If the INR or PTT comes back significantly elevated, meaning their blood isn't clotting properly, you simply cannot proceed straight to surgery. The bleeding risk would be far too high.
So what happens then? Does he have to fix it first?
You have to intervene before surgery. That might mean giving vitamin K or fresh frozen plasma, FFP, or something called prothrombin complex concentrate, PCC, if it's warfarin. If it's heparin, you might use protamine. Some of the newer drugs, the DOACs, have specific reversal agents. So that single lab result, a high INR or PTT, can completely change the immediate plan and timeline. You have to correct the coagulopathy to make surgery safe enough to even attempt.
Wow. So it's like these stat tests are doing a super fast systems check on the patient's engine before the race. Kidneys, heart, fuel load, blood counts, and the braking system, clotting.
That's a great analogy,
Yeah.
Kidneys, heart, blood composition, clotting ability. These are the things you need to know right now to assess the immediate risk and figure out what interventions are needed before you even think about the operating room.
It's a really concentrated burst of essential data. Okay, let's just circle back on that stat panel for a second. We listed UKE, Troponins T, Myoglobin, FBC, and coags. Thinking specifically about the cardiac markers, why order both Troponin T and Myoglobin? Why not just one?
Good question. It's about timing and sensitivity, really. Troponin T is very specific to heart muscle damage, and it stays elevated for quite a while. But myoglobin, while less specific because it's also found in skeletal muscle, rises much faster after injury, sometimes within an hour or two.
Whereas troponin takes longer.
Troponin T might take, say, 3 to 6 hours to become significantly elevated. So in a hyperacute emergency, getting both gives you the best chance of picking up very recent or ongoing heart muscle injury as early as possible. Myoglobin gives you that potential early warning, even if the troponin isn't positive yet. It maximizes your sensitivity in that critical early window.
Got it. Maximizing the chance of catching an acute cardiac event happening alongside the vascular one. Okay, so identity confirmed, reassurance given, stat labs are cooking. What about imaging? The protocol lists things like chest x-ray, duplex ultrasound, MRA, CTA.
Yes, it lists those common modalities. But, and this is a really key instruction, it explicitly states they should only be done at the specific request of Dr. Weir.
That sounds quite restrictive, centralizing the decision entirely with the surgeon. What's the clinical thinking behind that? Why not just have a standard imaging protocol?
It really comes down to minimizing delay and ensuring relevance. In these emergencies, time is tissue, or time is life. Ordering a battery of tests routinely can create serious bottlenecks waiting for scanner slots, patient transport, radiologist reports.
Things grind to a halt.
Potentially, yes. By requiring the surgeon's specific request, the protocol ensures that imaging is ordered only when it's truly necessary to answer a specific clinical question that will guide management and ordered at the right point in the process.
So the surgeon, having seen the patient, reviewed the initial labs, decides what's needed.
Exactly. Maybe the clinical picture is absolutely classic for acute limb ischemia, and the plan is immediate surgical exploration regardless of fancy imaging. In that case, the surgeon might say, no imaging, straight to theater. Or, if they suspect a ruptured aneurysm, a STAT-CT angiogram is essential to confirm it and see the anatomy, but maybe a routine chest x-ray can wait until after the life-saving op.
Or if it's maybe a DVT, a bedside duplex is the fastest way.
Precisely. Quick, non-invasive right there. The surgeon acts as a gatekeeper, choosing the right tool for the job at the right time, making sure imaging helps rather than hinders progress.
And just briefly, what do these different scans tell us in this context? Chest x-ray is for?
Baseline heart and lungs, essentially. Looking for fluid overload, pneumonia, things that affect anesthetic risk. Duplex ultrasound uses sound waves, great for looking at blood flow in real time. Finding clots, assessing vessel anatomy at the bedside, no radiation, no contrast dye.
And the big guns, MRA and CTA.
Magnetic resonance angiography and computed tomography angiography. These give you detailed anatomical maps of the arteries or veins. Really important for planning complex repairs, pinpointing the exact site of a blockage, a rupture, an aneurysm's neck. CTA is generally faster and more widely available in emergencies. MRA avoids radiation and sometimes contrast, but can be slower. Both usually require moving the patient to the scanner.
So the surgeon is like the mission controller, deciding which diagnostic data stream is actually needed right now and bypassing the rest to save time.
That's a good way to put it, yeah. Balancing diagnostic yield against the urgency of the situation.
Okay, so wrapping up this section on investigations. Advanced imaging isn't automatic. It's strictly driven by the surgeon's specific request to optimize speed and clinical value. Right, so we've got identity, stat labs giving us physiology, imaging decisions made. Now we get into the real core of the protocol, it seems. Section 4, patient preparation for surgery. This looks like a very detailed step-by-step sequence.
It is. This is really the engine room of the preoperative phase. It outlines all the crucial actions the team needs to take to get the patient optimized and ready safely for the operating room.
Step 4.1. The patient must remain nil per mouth from admission until surgery. Sounds absolute.
It is NPO, nil per us. Absolutely non-negotiable before anesthesia. The biggest reason is to prevent aspiration.
Food or liquid coming up from the stomach and going into the lungs.
Exactly. When you're under anesthesia, your normal protective airway reflexes are gone. If there's stuff in the stomach, it can reflux up and get inhaled. That causes aspiration pneumonia, which can be incredibly serious, even fatal. In an emergency, you often don't know when the patient last ate or drank, and stress and pain can slow stomach emptying anyway. So the default has to be nothing by mouth from the moment they arrive.
Okay, clear rule. Step 4.2. Apply an oxygen mask, 40% O2 mask at 5 liters per minute. Very specific. Why this setup?
Two main reasons here. First, supplemental oxygen boosts the oxygen levels in the blood. If you've got a limb that's ischemic, struggling for oxygen, maximizing the supply can potentially help keep tissues viable for longer.
Makes sense. Support the struggling tissues.
Right. Second, it's standard practice for pre-oxygenation before anesthesia. By breathing a higher oxygen concentration for a few minutes, you wash out the nitrogen from their lungs and fill them up with oxygen. This builds up an oxygen reserve.
A safety buffer.
Exactly.
Yeah.
It gives the anesthetist significantly more time during induction and intubation, or if there's any difficulty securing the airway, before the patient's oxygen levels start to drop dangerously. It's a major safety measure, especially in patients who might have underlying lung or heart problems. The 40% mask and that flow rate ensure they're getting enough oxygen effectively.
Got it. Oxygen for tissue support and anesthetic safety. Step 4.3. Assess vital signs every 15 minutes. That's pretty frequent. BP, heart rate, respiratory rate, O2 sats, temperature.
It has to be frequent because these patients can change rapidly. They might be bleeding internally and becoming hypotensive, or their blood pressure might be sky high from pain or stress. Heart rate could be racing, breathing could become difficult, oxygen levels might drop, fever could indicate infection.
So it's about catching deterioration early.
Yes, rapid detection of any instability. Are they heading towards shock? Is their BP dangerously high? Are they getting hypoxic? Catching it early means you can intervene quickly, fluids, maybe drugs to support blood pressure, adjusting oxygen, treating pain before they crash, maybe on the way to theater or just as they arrive. It's continuous surveillance.
Okay. Now, step 4.4 is marked as critical. Do not apply a blood pressure cuff or do venipuncture on the affected limb. Why is this so emphatically critical?
This is hugely important, especially if you're dealing with acute limb ischemia. Think about it. The blood flow to that limb is already severely compromised. If you put a blood pressure cuff on it and inflate it, you're essentially applying a tourniquet. You completely cut off what little blood flow might be getting through.
Worsening the ischemia.
Dramatically. Even the pressure between readings can compress fragile vessels. You risk tipping a salvageable limb over the edge into needing amputation, and doing venipuncture trying to draw blood or put in an IV line.
What's the risk there?
On an ischemic limb, you risk causing bleeding into the tissues, forming a hematoma. That collection of blood can then compress the already struggling arteries or nerves, causing more pain, more damage, potentially further reducing blood flow. You're essentially adding insult to injury on tissue that's incredibly vulnerable.
So it's like a handle with extreme care instruction for that specific limb, protect it from any further trauma or pressure.
Exactly. You want to avoid anything that could compromise it further.
Step 4.5. Do preoperative assessment, including a preoperative ECG.
Right, this is the focused history and physical needed before surgery. You're gathering key info for the surgeon and anesthetist. What are their other medical problems? Heart disease, lung disease, diabetes, kidney failure. Any previous surgeries or problems with anesthesia? What medications are they on? The physical exam focuses on the vascular issue, but also overall stability.
And the ECG, the electrocardiogram.
Specifically, looking at the heart's electrical activity. What's the rhythm? Atrial fibrillation is really common in these folks. Are there signs of a current or past heart attack ischemic changes? Any conduction problems, heart blocks? All this feeds directly into the anesthetic plan. It helps the anesthetist anticipate risks, manage the heart during the stress of surgery, and try to prevent cardiac complications.
Step 4.6. Insert an intravenous line and initiate 0.9% sodium chloride at 80 milliliters per hour, increasing to 100 milliliters per hour if weight more than 100 kilograms.
This is about getting that essential IV access sorted. That line is your immediate route for giving urgent drugs, strong painkillers, antibiotics, emergency meds if the condition tanks. It's also how you'd give fluids rapidly if they're hypotensive, maybe from bleeding, and how you'd give blood products if needed.
And the fluids themselves, the saline drip.
Starting the 0.9% sodium chloride, or normal saline, provides some baseline hydration. Remember, they're nil by mouth, maybe already a bit dry. It helps maintain general circulation and kidney perfusion, especially important if they've had contrast dye. The slightly higher rate for heavier patients, over 100 kilos, is just standard practice, adjusting maintenance fluids based roughly on body size.
Makes sense. Step 4.7. Assess and document any patient allergies, for example, iodine antibiotics. Seems straightforward, but critical.
Absolutely fundamental safety check. Missing an allergy can have catastrophic consequences, like anaphylaxis. Common culprits in surgery include antibiotics given just before the incision, and as we mentioned, iodine-based contrast dye used for imaging. You have to ask the patient, ask the family, document it clearly and prominently, and make sure the whole team knows. Avoidance is key. Step 4.8. Assess and document current medication, for example, anticoagulants, antiplatelets. We touched on why the coag profile is important, but this is about the specifics.
Exactly. It's not just knowing the INR is high, but why? Are they on warfarin? Which specific DOAC, apixaban, rivaroxaban, clopidogrel, aspirin, heparin? You need the specific drug name, the dose, and crucially, when they last took it.
Why is the timing so important? Because it tells you how much drug effect is likely still present. It directly impacts your assessment of bleeding risk, helps interpret those coagulation labs, tells you if you need to give a reversal agent and which one, and might even influence the timing of surgery or whether certain anesthetic techniques like spinal or epidural are safe. Getting the medication history wrong, especially with blood thinners, is a major source of problems.
Okay. Step 4.9. Administer all urgent and preoperative analgesia and medication as prescribed immediately.
This covers a few things. First, pain relief. Acute limb ischemia, for instance, is incredibly painful. Getting on top of the pain isn't just humane. It can actually help stabilize their vital signs by reducing that massive stress response. Second, preoperative medications often include prophylactic antibiotics.
To prevent infection after surgery.
Exactly. And these need to be given within a specific window, usually about an hour before the incision, to be most effective. So immediately means getting those time-critical meds in. It also covers any other essential medications the patient takes for chronic conditions, maybe blood pressure pills or heart rhythm drugs that shouldn't be missed even in an emergency.
Right. Keep their baseline conditions managed. Step 4.0. Only order blood for transfusion if specifically requested by Dr. Weir, for example, aorta aneurysm rupture. Back to the surgeon as gatekeepers, this time for blood.
Yeah, this balances preparedness with resource stewardship. Blood transfusions aren't risk-free reactions. Fluid overload, albeit rare nowadays, infection risk. And they cost money and take time to prepare. Typing and cross-matching isn't instant.
So you don't want to order it unless you really think you'll need it.
Precisely. By restricting orders to the surgeon's request, you ensure blood is prepared mainly for cases where significant blood loss is highly anticipated, like a ruptured aneurysm repair or maybe a very complex bypass. It avoids unnecessary work and cost for cases where major bleeding is unlikely. But when the surgeon does ask for it because they anticipate trouble, the system is primed to get it ready quickly.
Okay. Step 4.11. Keep the patient as still as possible. Strict bed rest. Why is this important?
Several reasons. For ischemic limbs, minimizing movement reduces the muscle's metabolic demand for oxygen, potentially helping borderline tissues survive. It also usually helps to reduce pain. In some situations, like if you suspect a deep vein thrombosis, DVT, or maybe an unstable plaque in an artery, keeping still might theoretically reduce the risk of a piece breaking off and traveling, causing a pulmonary embolism from a DVT, or distal emboli from an artery.
So minimizing demand, minimizing pain, potentially minimizing embolization risk.
And generally just keeping them stable and reducing the chance of accidental injury before they get to the controlled environment of the OR.
Step 4.12. Request the patient to remove dentures, jewelry, and contact lenses. Standard stuff, but why exactly?
Yep, standard pre-anesthesia safety. Dentures can become dislodged during anesthesia induction or emergence and block the airway, a nightmare scenario. Jewelry, especially metal, is a burn risk if surgical diathermy or cautery is used near it. Rings can also cut off circulation if fingers swell. Contact lenses.
And damage the eyes.
They can cause corneal abrasions if the eyes dry out while the patient is unconscious and can't blink. Plus, they make it hard to assess pupil responses if needed, so all these come off and get stored safely.
Step 4.13. Please sponge bath the patient with chlorhexidine soap if time allows. Skin prep for infection prevention.
Exactly. Chlorhexidine is an antiseptic that significantly reduces the number of bacteria living on the skin. Cleaning the skin, particularly near the planned surgical site, before surgery is a proven way to reduce the risk of surgical site infections post-operatively.
But it includes that crucial caveat if time allows.
Right. That acknowledges the reality of emergencies. If the patient is crashing or the limb is immediately threatened, you don't delay life-saving surgery for a sponge bath. It's an important step for infection control when feasible, but it doesn't trump absolute urgency. Get the patient to theater first if necessary.
Step 4.14. Provide the patient with the appropriate theater attire. Straightforward.
Yep, standard hospital gown, maybe a cap, ensures they're appropriately dressed for the operating room environment, maintaining dignity, while allowing access for lines, monitoring, and the surgical field.
Step 4.15. Request the patient or a family member to complete the pre-anesthetic form.
This is that focused questionnaire specifically for the anesthetist. It captures vital history points, previous anesthetics and any problems, family history of anesthetic issues, allergies, current health conditions, meds, smoking, alcohol, things relevant to planning a safe anesthetic and managing the airway.
And if the patient can't fill it out, too sick, too confused,
then having a family member complete it is invaluable. The anesthetist needs that information to anticipate potential difficulties and tailor the anesthetic plan. It's a critical piece of the safety puzzle.
Step 4.16. Request the patient to sign the hospital permission form and a family member to sign as witness. The formal consent.
Yes. Even in an emergency, the principle of informed consent needs to be upheld as much as possible. The surgeon should have explained the planned procedure, the reason for it, the potential risks and benefits, and any alternatives. If the patient understands this and agrees and has capacity to make the decision, they sign the form.
And the family member witnesses.
Usually witnesses the patient's signature and confirms the discussion happened. Of course, in dire emergencies where the patient lacks capacity and no family is available, surgery might proceed under emergency consent rules, but obtaining informed consent is always the goal.
And the very last step before heading off, step 4.17. Confirm which procedure is to be done on what site. Compare this with the patient, the family, and the theater list. The final check.
This is absolutely vital. It's part of the universal preoperative timeout or safety checklist, a final barrier against wrong patient, wrong site, wrong procedure errors. Just before the patient leaves the prep area, the team verbally confirms. Patient name, date of birth, what surgery are we doing, which limb, which side. They check this with the patient if awake, with the family, and critically, cross-reference it against the official operating theater list or booking.
Everyone has to be on the same page.
Everyone. The nurse handing over, the team receiving in theater anesthesia, surgery. It ensures complete alignment on the plan right before anesthesia starts, preventing potentially devastating errors.
Wow. That whole sequence, 4.1 through 4.17, it really paints a picture of controlled, purposeful activity. It's like a complex choreography designed to take a patient from arrival to being OR ready, safely and systematically, even with the clock ticking loudly.
It really is. A flurry of essential tasks. But each one has a clear rationale rooted in safety, physiology, and preparedness for both surgery and anesthesia. It imposes structure in a potentially chaotic situation.
Let's think about how this plays out in a tricky situation. Say a patient comes in with really bad acute leg ischemia, but they also have end-stage kidney failure, they're on dialysis, and they take one of the newer anticoagulants, a DOAC, for their atrial fibrillation. How do those initial steps, the stat labs like UK and COAGs, and the medication review in step 4.8 immediately shape the plan?
Okay, that's a great complex scenario that highlights the protocol's value. So the stat UK comes back confirming severe renal failure, high creatinine, and urea. Right away, that impacts everything. Drug doses, antibiotics, pain relief need careful adjustment. Fluid management needs to be cautious. And critically, if you were thinking about a CT angiogram with contrast to map out the blockage,
You'd be very hesitant because of the kidneys.
extremely hesitant. You'd strongly favor duplex ultrasound first, or maybe consider a non-contrast MRA if available and appropriate. So the UK result immediately alters your diagnostic pathway. Simultaneously, the medication review, step 4.8, identifies the DOAC. Now, unlike warfarin, where the INR tells you the level of anticoagulation, standard labs like PTT might or might not reflect the DOAC's effect well, depending on the specific drug. But knowing they are on a potent anticoagulant immediately raises a huge red flag for surgical bleeding.
So you can't just rush to surgery.
Absolutely not. You need to know when was the last dose. Is there a specific reversal agent available for this DOAC, and is it indicated? This might trigger an urgent call to hematology. It will definitely be a major discussion point with the anesthetist regarding bleeding management and maybe neuraxial anesthesia being unsafe. So those initial steps, getting the labs, getting the med history, don't just tick boxes. They fundamentally redirect the patient's management pathway within minutes of arrival. Delaying surgery for reversal might become necessary, imaging choices change, anesthetic plans adapt.
It really shows how these aren't just sequential steps, but interacting layers of assessment. Okay, let's do a quick mega recap then, pulling together everything from arrival right through that detailed preparation phase, sections 1 to 4.
Right. So we started with section 1. Patient identity, absolute critical, multi-point confirmation sticker, patient verbal, family coupled with that essential welcome and reassurance. Safety and humanity first. Then section 2, stat blood test. That immediate panel, UKE, kidneys, electrolytes, Troponins, myoglobin, cardiac status, FBC, blood counts, infection, inflammation, and coagulation profile. And then our PTT for bleeding risk. A rapid physiological snapshot. Section 3 covered other investigations imaging like CXR, Duplex, MRA, CTA, emphasizing these are not routine, but ordered specifically by the surgeon to maintain efficiency and relevance. And then the big one, section 4, patient preparation for surgery. This huge sequence covered everything from nil per mouth, 4.1, and oxygen, 4.2, to frequent vital signs, 4.3, the critical don't touch the affected limb rule, 4.4, pre-op assessment SEG, 4.5, for access and fluids, 4.6, assessing allergies, 4.7, and medication, especially antithrombotics, 4.8, giving urgent meds analgesia, 4.9, the specific policy for ordering blood, 4.10, strict bed rest, 4.11, removing personal items, 4.12, the chlorhexidine bath if time allows, 4.13, theater attire, 4.15, completing the pre-anesthetic and hospital permission forms, 4.15, 4.16, and that final vital procedure site confirmation check, 4.17.
That's incredibly thorough. It lays out a clear, standardized, safety-focused pathway. Taking a patient through the initial chaos of arrival, diagnosing key issues rapidly, and then systematically preparing them step by step for the operating room, optimizing their condition as much as possible under pressure.
Exactly. Each step is designed to mitigate risk, ensure readiness, and contribute to a better outcome. It brings order to the urgency.
Okay, so the patient is prepped, checked, and ready for transfer. Let's look at the final part of the protocol, section 5, theater. What does it say about the move to the OR and the immediate post-op plan?
Right. Section 5 covers the final logistics. First, it encourages family to accompany the patient to the entrance of the theater complex, a small but important human touch. Second, it actually specifies the likely operating room, theater 15.
Interesting. And then, crucially, where the patient goes after the surgery.
Yes, it states, after the procedure, the patient will be transferred to the cardiac HCU or ICU. That's cardiac high care unit or intensive care unit. So a high dependency environment is the planned destination.
No ambiguity there. High-level care expected.
Definitely. And finally, it notes a specific place for families to wait an area adjacent to the theater complex and explicitly states that Dr. Weir will communicate with them there after the procedure.
What's the significance of these points? The family presence, the specific theater, the ICU destination, the communication plan?
Well, allowing family to the theater entrance acknowledges the emotional weight of that moment, providing a final point of connection before separation. Specifying theater 15 might mean it's the dedicated vascular theater, maybe with fixed imaging equipment or specialized staff always available. The destination cardiac HCU or ICU sends a clear message about the expected level of postoperative monitoring and support.
Because these patients are still very fragile after surgery.
Extremely. After major emergency vascular surgery, they're at high risk of bleeding, blood pressure instability, heart problems, kidney issues, breathing difficulties, you name it. HCU or ICU provides that necessary level of continuous monitoring, potential ventilator support, specialized drips, and intensive nursing care that you just can't get on a regular ward. It anticipates the high-risk immediate recovery phase.
So the surgery isn't the end of the high-risk period.
Not at all. The immediate post-op phase is critical. And the final point about the waiting area and communication plan, that's about managing family anxiety. Knowing where to wait and that they will get an update directly from the surgeon provides crucial reassurance during what can be a long and stressful wait.
Okay, so the protocol finishes by guiding the patient to a specific theater, planning for high-acuity post-op care, and ensuring family communication is factored in.
And importantly, the source material also mentions that this admission protocol doesn't exist in isolation. It actually refers to other related protocols that it links into.
Oh, really? Like what?
It mentions a general postoperative protocol, a separate blood pressure monitoring protocol, which really underscores how vital controlling hemodynamics is after these ops. Another specific postoperative protocol attached to the prescription chart, probably detailing standard medication orders and even a specific discharge protocol, including a script for take-home meds.
So this detailed admission process we've just dissected is actually just the front door to a whole system of standardized care pathways for these patients.
That's exactly what it implies, a continuum of care managed systematically using protocols from the moment they hit the door in crisis, right through surgery, recovery, and eventually discharge planning. The goal is consistency, best practice, and minimizing variability at every stage.
We've certainly taken a deep dive into this protocol today, from that initial critical identity confirmation and rapid diagnostics, through that incredibly detailed multi-step preparation phase, and finally, the clear path into theater and onto high-level post-operative care. It's quite the system.
It really is.
Yeah.
And having such a rigorous, structured approach is, I think, absolutely essential in the world of emergency vascular surgery. It's complex, it's high stakes, time is always critical. This kind of protocol standardizes the crucial steps, it minimizes variation between cases or clinicians, and it acts as a vital safety net when the team is under intense pressure.
It allows them to focus on the core surgical problem, knowing the foundations are covered systematically.
Precisely. Adhering to it ensures best practices are followed consistently, even in the heat of the moment.
But Misa, you touched on this earlier with that complex patient scenario. These emergency vascular patients often don't fit neatly into boxes, do they? They come with multiple severe comorbidities, weird anatomies, unexpected complications, things a protocol can't always anticipate perfectly.
No, they certainly don't. And that brings us to perhaps the most interesting point for clinicians listening. This protocol provides an essential, rigorous structure. But how does the experienced surgeon or clinician balance that strict adherence, making sure every box is ticked, every safety check done with the clinical judgment, the flexibility, the adaptability you absolutely need to manage these really complex, atypical, or crashing patients effectively?
Where does the protocol end and the art of medicine begin?
Exactly. The protocol is the framework, the safety net, the standardized pathway. But dealing with the unique complexities of each individual patient, especially under duress, still requires immense skill, experience, and that ability to think on your feet, perhaps deviating slightly when clinically justified, while always keeping the principles behind the protocol in mind. It's that interplay between the structure and the clinical acumen that defines expert practice in these situations.
A fascinating thought to end on. The protocol provides the map, but ultimately, the skilled clinician still needs to navigate the journey.